Assalamualaikum dan salam sejahtera saya ucapkan kepada para hadirin yang dapat bersama-sama kita dalam sesi CME yang dianjurkan oleh SEHAT Selangor, iaitu salah satu program di bawah Kerajaan Negeri Selangor untuk kita menghadapi kenaikan isu-isu kesihatan mental yang semakin kritikal, bukan sahaja di Negeri Selangor tetapi juga di seluruh negara. Program ini dibawakan dengan kerjasama daripada International Islamic University Malaysia dan juga Malaysian Psychiatric Association MPA. Untuk sesi kita pada hari ini, tajuknya ialah Psychotropic Medications in Primary Setting. Sebagaimana yang kita sedia maklum, kes-kes psikiatri ataupun kes-kes yang psikosis bukan sahaja di manage di peringkat-peringkat tertiary center ataupun secara spesifiknya oleh psikiatris, tetapi kebanyakan kes ini juga ada datang ke klinik-klinik di primary care, terutamanya di GP-GP, dan kadang-kadang kes-kes ini memang benar-benar memerlukan rawatan dan ubat-ubatan yang tertentu. Walau bagaimanapun, isu yang sering kita hadapi ialah bagaimana untuk memberikan ubat-ubatan ini. Sama ada dari segi effectiveness ataupun dari segi availability, sama ada ubat itu tersedia atau tidak. Dan yang paling penting ialah kos, kerana kita sedia maklum kos-kos rawatan untuk penyakit-penyakit psikiatri ini agak tinggi. Oleh itu, pada hari ini bersama-sama kita ialah Dr. Sid Hunfei, seorang pakar psikiatris dari Dr. Sid Specialist Clinic yang akan memberi pencerahan bagaimana untuk kita manage pesakit-pesakit psikiatri, terutamanya pesakit-pesakit yang mempunyai kes-kes psikosis di primary care setting, dan bagaimana untuk memberikan rawatan ubat-ubatan kepada para pesakit ini. Untuk itu saya ucapkan selamat datang kepada Dr. Sid dan saya serahkan sesi ini kepada Dr. Sid. Silakan Dr.
Alright, hello, good afternoon. Thank you Dr. Faiza for the kind introduction. Alright, so I'm Dr. Sid, saya seorang pakar psychiatry. Alright, so thank you for having me today to share with you all regarding these psychotropic medications. Okay, so I'll be using BM English mixture lah, boleh kan? Okay. Okay, so today's topic is about psychotropic medication in primary care settings, right? I think I was given the task to discuss about the safe and effective prescribing of the psychotropic medication for people with mental health issue, right, in the primary care setting. All right, next slide, please. So, but of course, there's before we go into details, all right, let me introduce a bit about what is psychotropic medication. You know, basically, tak kira lah ya GP ke, klinik kesihatan, okay, you will definitely see a lot of psychiatric patients with a lot of psychiatric disorder. All right, it can be from insomnia, stress, and anxiety, depression, and even psychosis also. Right, because I believe rasakan ramai yang akan take the opportunity to visit the GP, right, nearby, or even to the clinic kesihatan instead of straight away dia datang jumpa pakar psychiatry in the hospital setting, or also in the private clinic setting. Right, I think the previous CME also mentioned that the GP is the gatekeeper as well. So there's a lot of reason that people are willing to see the GP than straight away go to the specialist service. Contoh, they are more comfortable with all the GP, their family doctors. All right, they are due to the convenient, okay, nearby, easy access. All right, and then of course not everyone were aware that all these are psychiatry issue as well. That's why they do not know where to get help. So they do not. That's why that's one of the reasons that they do not straight away go to the specialist center. So you guys will help us, definitely will be the first line to help us to see a lot of all these psychiatric cases. All right, and And furthermore, dalam 2-3 tahun ni kan, alright, I setuju that the psychiatric cases or the mental health disorder or mental health cases has increased tremendously. Alright, banyak case kan, in your practice you akan jumpa a lot of insomnia, a lot of anxiety, a lot of depression. So when you see this kind of patient, alright, the special population, alright, then you might need to use a lot of psychotropic medication. So when we talk about psychotropic medication, basically by the name itself, it means that medication that can use to treat the psychiatric disorder or psychiatric condition. Sometimes not even not to the extent of the disorder, but the condition. Yes, we can use a bit of psychotropic medication. All right. Of course, we know that the psychotropic medication basically is the medication help to manage, or it can have the effect of someone's behavior, all right, someone's mood, thoughts, and even perception. Okay, so I think from the previous CME, you all have learned a lot about this depression, anxiety, psychosis, all right. But from the feedback, I was told that it's better to have less slide than so that we can discuss more on the more relevant practical issue. So you guys, if you have any question, please post up the question. I will try my best to explain or to answer your question as much as possible. All right. So that it's 3 p.m. now and it's a Monday. We get Monday blue, and it's post lunch. I do not want to burden you all with all the very wordy kind of presentation. So my presentation is very simplified, minimal wording, but more on the discussion. If you all have any question, please, we can always discuss. Okay, so when we talk about this psychotropic medication, of course, it's not only the medication that we prescribe, all right? In the market, we have prescription medication. Of course, we have illicit medication or also all the substances, okay? So how does it work? All these psychotropic medication, basically, they can adjust, right, the level of all these neurotransmitter or brain chemical to improve the symptoms, right? So as you can see from the slide, 5 major classes of psychotropic medication. Okay, we have antidepressant, we have antipsychotic, we have mood stabilizer, we have stimulants, and we have anti-anxiety agent. All right, I suppose all these antidepressant, antipsychotic, and anti-anxiety was previously discussed in the other CME, and I'm sure you all are very familiar with all these medications. But I think in your practice, you can guna a lot antidepressant, a lot antipsychotic. All right, so just let me go into each of the classifications. So while we are discussing the classification of this psychotropic medication, perhaps we can discuss about some safety issue, what are the common problems that we encounter when we try to prescribe such medication, and etc. If you have any question, yes, please ask. You can always stop me. We can discuss on that, no issues. All right. Okay, hopefully I'm not too fast. Okay, thank you, Dr. Faiza. Can you move on to the next slide? All right, of course. The first one we are going to talk about is the antipsychotic. All right, so these are the common medication that we are going to, we use commonly in our settings, all right, to treat psychotic disorder. But of course, all right, when we talk about antipsychotic, it's not merely just for psychosis, but sometimes we use we use in the mood disorder as well, such as bipolar disorder. We use in augmentation of major depressive disorder. All right, so typical antipsychotic, atypical antipsychotic. I'm aware some of the GPs, right, they use a lot of typical antipsychotic. Some of them are very familiar with it. So for example, like perfenazine, haloperidol, okay? Or I do have a lot of colleagues, all right, or GP friends use a lot of atypical antipsychotics such as aripiprazole, Of course, Zolpidem, no, like olanzapine, quetiapine, risperidone, right? I think you are very familiar with all these medication, all right? So, I mean, what are the issues that, commonly seen? Because a lot of time patients come to you, they do not come with early symptoms, right? A lot of time when family brought them to see the doctors, I think their condition has worsened. Whether jadi teruk, bahaya, all right, then the family will bring them. So a lot of time, all right, when they come to see you, they are already in the serious stage. So we need to understand the concept of the medication, the mechanism of the medication. Then only we can decide which medication is more suitable for which group of patient. For example, all right, cannot sleep, patient who having psychotic symptoms, patient who cannot sleep. So we will tend to use more on medication that can have a sedative effect. For example, such as quetiapine, such as olanzapine, right? A patient who has some obesity issues, we will try to avoid medication that can have a metabolic syndrome side effect, such as olanzapine, right? So having said that, meaning before we prescribe the medication, right, for psychotic disorder, of course we have to be confident about the diagnosis. We must be confident about the disorder, right, and then at the same time we must be familiar with the medication, or else you wouldn't know what to expect after started the patient on medication. Okay, so about when we prescribe this medication to the patients, we have to explain the indication, what are the expected side effects, or what are the possible side effects to the family members as well, so that they can help to monitor at home. All right, I'm sure, I mean, we all are very familiar with all this psycho education. All right, so these are the few things that we will do when we try to prescribe medication. Right, antipsychotics sometimes also being used in some dementia patients, right, and also children as well. All right, so these are the few things that usually we will pay more attention. But I have a few of my GP friends also. They are actually quite confident to use antipsychotic such as olanzapine, quetiapine, and risperidone. I mean, it's good. All right, at least patient come to you, they trusted you. Okay, so the duration of the untreated psychosis, it used to be very long. The duration of the untreated psychosis, if you according to the previous guideline, Malaysia CPG, it can be up to 2 years or more. All right, so if the patient willing to come and see the primary care, right, the GP, the clinical kesihatan, yes, if you are confident, please treat the patient so that we can actually shorten the duration of untreated psychosis. If the duration is gets longer, then of course the symptoms can be more severe on that. Okay, so this is basically about antipsychotic. But if you go through our Malaysia CPG guidelines on antipsychotic, meaning the schizophrenia guideline, they have this introduction of antipsychotic. Of course, there are things that we need to monitor. All right, need to monitor. So meaning once you started on patient on certain antipsychotic, then some blood parameters that we need to monitor. For example, like maybe sugar, cholesterol, right? This thing, because some medication has the risk of metabolic syndrome as well. Okay, and if you are aware of any patients is taking clozapine and they come to you with a lot of infection symptoms like URTI, I mean, if you're aware of the side effect of clozapine like a granulocytosis, I mean, I think it's good if you can just proceed with an FBC to look at the neutrophil count, to look for the side effect of granulocytosis, right? If you detect anything abnormal, yes, you can always refer to the tertiary setting as well. Okay, and And for antipsychotic as well, okay, when we try to prescribe to the patient, especially the new treatment naive patient, okay, usually we will practice the concept of go slow, start low, all right, meaning we start patient on lower dose and we titrate the medication slowly, all right. If you're aware of this, one of the complication of this antipsychotic medication, all right, in a treatment naive patient is called neuromelanin syndrome, or in short we call it NMS. So ubat macam ni kan, kalau kita bagi treat kepada pesakit yang tak pernah makan ubat antipsychotic, kita bagi dos yang tinggi atau kita bagi titration, maksudnya kita naik ubat ni, dos dia terlalu cepat, dia boleh membawa komplikasi NMS. NMS is a medical emergency high mortality rate. Alright, so we need to be a bit careful on that lah. So what kind of patient can develop NMS, neuromelanin syndrome? Like I said, young patient, elderly patient, treatment naive patient, patient who has previously head injury, patient who has alcoholic patient, dehydrated patient, or patient with multiple comorbidities, they all are at the high risk to develop NMS. So meaning when we start the patient on all these antipsychotic or basically any of the psychotropic medication, then I think we need to go a bit slow, and then we even start patient on the lower dose, all right, instead of going for full force, start patient on high dose, titrate the medication very fast, all right. Have to be careful on that. Patient can come back with all the rigidity, high grade fever, palpitation, difficulty breathing, all right. So these are the few things that we need to monitor, especially we are going to start patient on a new patient, a treatment naive patient, or antipsychotic, all right? But in terms of availability of medication, I don't think there's issue for antipsychotic. I think even our primary setting, all right, of course, clinical kesehatan, they have typical antipsychotics such as haloperidol, pirfenazine, all right. Atypical, if I'm not mistaken, they have risperidone as well, all right. Of course, some medication like aripiprazole or paliperidol and quetiapine, all these are this A medication, AS straight sometimes, all right. That's when you only can get in a tertiary hospital with a psychiatrist available, then only you can get the medication. But doesn't mean that all patients coming, you have to start them on a high-fi medication. You can start them with any medication that is available in your settings. Yeah, if patient develops side effect or patient doesn't show good improvement, then you can always refer out, no issues on that. Okay. So I think that's all for antipsychotic. So far, any question on antipsychotic? All right. Okay. I think still early, not too many people here. All right. Kalau tak ada soalan, then we move on to the next slide. Okay, yes, anti-anxiety. I think I rasa ubat ni ya, alprazolam, clonazepam, diazepam, or lorazepam is a very common medication. I rasa semua orang pun familiar kan. But of course, like alprazolam, right, the original Xanax, we have a lot of generic. Right? We have Prozovex, we have Zolvex, we have Asolan. Clonazepam in Malaysia, we have Rivotril or Rivotril. Diazepam, we have Valium. Different brand. Lorazepam, of course, we do not have 81 here, but we are using Lorans, we are using Apo. There's a lot of different medication, but all serve the same effect, anti-anxiety. But this is one of the most macam kata ubat yang walaupun guna untuk merawat takut-takutan, gelisah, rimas, but actually this medication causing a lot of anxiety to us as well, all right, because this is one of the most addictive medication, all right. Anti-anxiety, or we call it sometimes anxiolytic, all right. Of course, it can treat different type of anxiety disorder, all right, including social phobia, generalized anxiety disorder, panic attack, all right, specific phobia, A lot of time we use it for sleep disorder as well, panic attack, stress, all right? But do remember, because a lot of time we know how to start the medication, but we always forget how to off the medication. So end up patient will be on the same medication for long, and then patient develop dependency, patient develop tolerance to all this medication. All right, because there's a lot of issue of this anti-anxiety, a lot of side effect. Of course, you're going to affect our cognitive function, right? Such as memory, organization, all this can be affected. All right, and then a lot of time we have difficulty to sustain the availability of this medication. Maksudnya kan ubat-ubat ni selalu tak ada stok, ubat ni tak ada, ubat tu tak ada. Once patient is get hooked with this medication, and then when they cannot get the medication, then they suffer because they might have withdrawal symptoms, you know, and then they without the medication, it cannot help them to control their whatever anxiety or phobia that they have been used, all the while they have been having it. So really need to be very careful, you know, to start patient on all this anxiolytic medication. For me, I always want to ask myself, all right, why do the patient need this anti-anxiety? Apa sebabnya dia perlukan anti-anxiety? Of course, if you ask patient, they will choose to maintain this medication and off any other medication. Right? If they're coming with, kalau dia datang kan masalah tidur. So if I put them on other medication, SSRI, you know, antipsychotic, whatever, no, they will tell me, doctor, I tak payah ubat lain, I hanya nak ubat anxiety ni. Why? Because for them, this works well. Right? This help them to sleep, they feel good. But a lot of time, we need to explain to them the side effect of this medication. All right? So, like I said, I always ask myself, mengapa pesakit ini perlukan anti-anxiety? Ada sebab? Is it because the patient is depressed? Is it because the patient is anxious? Or is it because of something else? We always spend time to look into the root cause of it. If we think that patient is having anxiety, then we treat the anxiety, meaning we use antidepressant, anti-anxiety like SSRI to treat the underlying causes instead of just using anti-anxiety agent. If patient having insomnia, same thing. We try to find out why patient is having insomnia. Is it part of the depression? Is it part of the psychosis? Or is it other reason, or is it due to medical problem, maybe hormone imbalance, hyperthyroidism, right? We try to look into it so that we can treat the underlying causes. Okay, I mean, I wouldn't disagree with this, saying that, you know, anti-anxiety is definitely a very good medication in terms of helping them to control or to reduce their anxiety. But the side effect of it, the side effect profile and the dependency and the tolerance, really patient will suffer if they cannot get the same medication again. All right. So this is anti-anxiety. I'm sure, I mean, during your practice, you will encounter a lot of clients coming in asking for, you know, alprazolam, diazepam, lorazepam, right? They all like to go for window shopping as well, you know, try to come to this clinic to ask for medication. Tak kira lah berapa dia dapat, and then they go to another clinic to ask for the same medication. I'm aware, you know, some of the patients even got blacklisted from the nearby clinic as well, right? Because of their drug-seeking behavior. But a lot of time, we will try our best to help them, you know, in terms of help them to treat the addiction or all this anti-anxiety medication, and to help them to treat the underlying problem as well. Okay, so remember, all right, I mean, usually when I started the patient on all this benzodiazepine group of medication, I will try my best to let them understand the side effect of it, so that they do not have the idea that, oh, this will be the best among all the medication that the patient is receiving. All right, and if you explain clearly enough, a lot of time patient even will try not to take this medication. They will try seriously. I have a lot of clients, you know, say, after you mentioned this side effect, you know, I better don't try it. Don't prescribe to me, right? But of course, some patients, they will ask for it more, so we need to deal with them carefully. Okay. All right. Any question about anti-anxiety? If yes, please let me know. All right. Or you can even share your experience of using this anti-anxiety in your clinic as well. Okay. And be careful on anti-anxiety as well, because a lot of time they will use this medication to sleep, all right? And then for a lot of many patients of mine, okay, when they first come to see me, they're having sleep issue, but of course they do not know where to get the medication. A lot of time they will start using alcohol, all right? So meaning some of the patients will use alcohol to help them to sleep. So later on, when they found out about anti-anxiety, the benzodiazepine, then they will start mixing the alcohol and also the benzodiazepine. So this is life-threatening, all right? So need to advise them when you put patient on the anti-anxiety that, you know, be very cautious by using that anti-benzodiazepine medication, and try not to use it together with alcohol, or even some opioid medication also can increase the risk of overdose. Need to be very careful on that. All right. So anti-anxiety, yes. Stimulants, I don't think in primary settings, all right, you will use a lot of stimulant. All right, correct me if I'm wrong, all right? But I don't think that in your setting you will use stimulant. But stimulant is the drug that mainly used to treat ADHD, or sometimes we use it to treat narcolepsy as well. Okay, so yeah, but of course the main one of the main issue of all these stimulants, right, like amphetamine, right? We have Ritalin in Malaysia, all right, and then yeah, we have Concerta, we have Strattera, but all this medication, okay, again, is a stimulant. It will cause addiction as well. So we need to be careful on that. I mean, lately, we have received a lot of new cases, right? Came to us, claim that they are having ADHD, want to start on all these stimulants. But when we go into it, when we talk to them, when we assess them, actually a lot of time they are having some anxiety or they're having depression, which can affect their cognitive function, right? Which can affect their cognitive function. So meaning become poor focus, poor memory. But for them, all right, because some of them are because of their friends, you know, or they read through some literature, so they self-diagnosed as ADHD. But a lot of time, no, they're only having some anxiety or depression, right? Which the cognitive component of the anxiety, depression mimics the symptom of ADHD, right? So, but usually I suppose let the expert who manage ADHD to decide on this lah. Okay. All right. So let's see. All right. No question. We move on. The next slide. Okay. Okay, so this is antidepressant, SSRI, SNRI, MAOI, tricyclic. Of course, as all these antidepressant mainly is used to treat different type of depression, all right? Among of them mainly is major depressive disorder, bipolar disorder. We won't use them to treat anxiety disorder, generalized anxiety, panic, PTSD, all right? So what's the difference? SSRI, selective serotonin, SNRI, serotonin with norepinephrine. It works a bit different from SSRI. They increase both the dopamine and norepinephrine, right, to improve with the symptoms, all right? So MAOI is a very old medication. Basically, we do not use nowadays, but of course, some of the senior psychiatrists, some of the senior private psychiatrists, they are still using, but because of the side effect profile, you know, this MAOI cannot be taken with certain food, or else it will cause hypertensive crisis, and they can increase the blood pressure to a very dangerous level. Food that has high tyramine, such as cheese, you know, so many kinds of cheese, pickles, or even some wine, you know, they have this theramine which can interact with the MLI and cause some emergency. All right. TCA, again, TCA is a old generation antidepressant. Okay, nowadays also we seldom use because the availability of a lot of new medication. All right, so TCA we seldom use that. All right, because of the side effect. For example, cardiotoxicity, weight gain, right? All these medication. All this the side effect of the medication. So we try not to use that as well. All right, but I'm sure you are very familiar with especially the SSRI group of medication, easily available. All right, if you can diagnose a patient with all the depressive disorder or anxiety disorder, and if you are confident enough, then start the patient on the medication. Okay, but again, please practice the principle of start low, go slow. All right, all these medication, antidepressant. It takes about, ambil masa about 2 to 4 weeks lah. It takes about 2 to 4 weeks to be effective. All right, so we have to go slow, we have to be patient, we have to explain to the patient. The most important thing is we have to explain to the patient. Kena terang, explain to the patient. Kalau tak kan, patient in 3 days, they will come back to you. Doktor, mengapa ubat ni tak jalan lagi? Mengapa I tak rasa apa-apa pun? This is common because all these SNRI, basically antidepressant, it takes about at least 2 weeks to be effective. All right. So with your explanation, then it can manage their expectation. Or else they will come back. They will come back. All right, very fast. They will call you. They will come to a clinic. They will ask you why this medication is not helping. Things like that. Okay, I think easily available. We have Lesapro nowadays. We have fluvoxamine, we have sertraline, SSI. We even have fluoxetine. Fluoxetine is Prozac. All right, SNRI, we have duloxetine, venlafaxine, we have desvenlafaxine. I think these are the few medications that we commonly prescribe for our patient. I mean, I would say SSRI relatively safe. All right, we can use it in children, we can use it in adult. All right. Okay. Okay, so if you have any question regarding all these SSRI, SNRI, or even you want to know more about MAOI or TCA, yes. Sometimes we use a TCA for cases like OCD, like clomipramine, nortriptyline. We use that for cases like OCD. All right, or I'm aware that some of our gastro colleagues also using a lot of amitriptyline to manage their gastritis patient as well. All right, so each medication you have to familiar with the indication, the side effect, and the profile, and also the drug-drug interaction. Okay. Of course, if you ask me, sometimes we will refer to the books or internet to check on the certain medication, the drug-drug interaction, I think, before we prescribe it to the patient as well. Okay, this is basically about the, what do you call that, the antidepressant, or antidepressant that used in managing of all these anxiety and depressive cases. All right, I think at this point of time, the most common prescription I see maybe in the primary setting, I think will be escitalopram. All right, of course, the other group is Remeron group. All right, mirtazapine is a NASA group. All right, a lot of my colleagues, a lot of GP that I'm aware is using Remeron, mirtazapine. All right, it's an antidepressant, can help with the anxiety symptom, and the best thing is can help with the sleep as well. But of course, and Remeron has its own side effect. So meaning when you prescribe to the patient, you need to explain and you need to monitor the side effect. For example, constipation, weight gain, dry mouth, all this you need to explain to the patient, or else patient will come back with a lot of complaint about all this medication. Okay. So far, any question about antidepressant, any medication that you are facing problems, or please, you can always bring up, we can always discuss over here. All right. All right. So next, let's move on. Okay. The next group will be the mood stabilizer. I'm not sure whether how frequent are you are using what do we call it, mood stabilizer, carbamazepine, we have lamotrigine, we have epilim as well. All right. All right. Usually we will use this kind of medication is either for mood disorder like bipolar disorder, or sometimes in resistant depression, or in depression that does not respond to the conventional depression, right? We will use that as an augmentation as well, all right? Like lithium gold standard for depression, all right? If you follow the Malaysia guideline or even the CAMEC guideline as well, lithium is it's always the gold standard of to manage all this depression or mood disorder. Okay. Okay, so but because of all the side effect profile, that's why, all right, I'm not sure whether you guys are actually using that a lot or not, but yes, we are using a lot. Okay, but we need to know the side effect. For example, like lithium, all right, lithium has a very narrow therapeutic level, meaning whenever we started the patient on lithium, or whenever we are just hold on for a while. Yeah. All right. Okay. So sorry. So the lithium side effect, like I said, the very narrow therapeutic side effect that we need to monitor closely. We have to subject patients for therapeutic dose monitoring. All right. And teratogenic side effect as well. So we cannot use it in the pregnant lady. Same to do. So epilim as well. Epilim nowadays they have this guidelines saying that we do not use it in a childbearing age lady, all right, because of the teratogenic side effect. In fact, when we wanted to start patient on this epilim, a lady epilim, which is in the child bearing age, right? We need to get their consent as well, of course. But before we get their consent, we need to explain to them clearly regarding the side effect of this medication. Carbamazepine, yes, right. All this anti-epileptic medication, yes, we do use, but we need to be very careful of the side effect as well, right? Like Steven Johnson syndrome as well, right? Lamotrigine, we need to be very careful on that. Okay. So, but I'm not sure, do you all start patient on a mood stabilizer? I think a lot of time, if your patient really need a mood stabilizer, if you are not confident, you can always refer out to refer out to the tertiary center or to the specialist center to start patient on this mood stabilizer. All right. Okay. All right. Yes, I saw a question here. All right. Hold on. All right. What do you think of role of pregabalin and Lyrica in treating anxiety disorder? Is easier prescribed as in GP patient or buy from pharmacy? Yes. All right. We do use pregabalin to treat some anxiety patient. For example, if patient doesn't respond to all these typical antidepressant like SSRI or SNRI, yes, or patient develop side effects such as maybe some patient might have some bleeding disorder with SSRI. Yes, we do use pregabalin to treat to manage the anxiety, for example, like generalized anxiety disorder. All right. Accessible in GP practice, yes, buy from pharmacy. But again, the other issue is if all this medication easily available in pharmacy, then of course you need to psychoeducate the patient regarding all this medication, or else patient might just getting the supply from the from the pharmacy without any proper monitoring and any proper adjusting of the dosage as well. Yep, yes, yeah, but we do use pregabalin to manage the anxiety as well. Okay. Okay, any question for mood stabilizer? If no, then we move on to the next slide. Okay, so this is FDA approved pediatric age. If you come across, but pediatric cases sometimes, right? These are the few medication, like you said, mainly used to treat MDD, used to treat GAD, or used to treat OCD as well, right? Childhood analysis, yes, imipramine. These are the few medication that FDA approved. But I think a lot of time we are more comfortable by using escitalopram or Prozac fluoxetine, right? These are the medication. So in to mention about this antidepressant, all right. So not sure whether you all heard about all these black box warning. All right, of course, FDA did mention about increased risk of suicidality in a child and adolescent patient. All right, so whenever we start patient, a younger patient, all right, on antidepressant, child and adolescent, well, we will usually advise the family, right, to monitor closely, especially during the initial period when you started the patient on medication. Okay. Okay. But of course, since this is a child patient, if you are not comfortable to manage a child patient or not confident to start patient on any medication, I mean, we can always, refer out the patient. All right. But of course, if you are confident, if you know you have experience on managing, then why not? Okay. All right. Okay, next. Right, again, just now was the antidepressant. Then this one will be the atypical antipsychotic. There are some range, some different medication that can approve for pediatric use. All right, of course you can go through this later. All right, so in a psychiatry setting, we manage child patient, we manage special population, the child patient, the elderly patient, or even the pregnancy patient as well. Older adults, the elderly, we need to be very careful when we wanted to give them medication, because they might miss the medication, or they might tend to take more of the medication, so have a higher risk to get for them to get overdose. They might be forgetful and then they overtake, taking again and again. All right. Or sometimes elderly, they might be very sensitive to the medication. Again, we have to apply the rules of start low, go slow. All right, the dosage might be different, and of course, we need to look into their organ, their kidney profile, their liver profile. A lot of time, we might need to use a different dose compared to adult, or maybe use a lower dose when we want to start them on the medication. All right, patient always coming with sleep issue. We do not prescribe, we try not to prescribe any benzodiazepine for them. It might worsen their cognitive function. It might cause, the fall at night. Right? All these the things that we need to consider. If any of the patient develop, any of the patient get pregnant, while on treatment or before started treatment, all right, I think it's better for you all to, to refer to the tertiary care for the management of pregnancy, pregnant lady with mental health disorder then. Okay. So, all right. Okay. During these 2-3 years, or because of the COVID, and then a lot of patients actually, due to the MCO or whatsoever reason, a lot of patients actually defaulted their treatment. All right, that's why it causes a lot of relapse. They do not dare to go to the hospital to pick up their pills, to see the doctors. All right, some even defaulted their lab tests. For example, patient on clozapine, they need to go for their weekly or monthly blood test, FBC, also they might defaulted. That's why causing a lot of side effect of the medication as well. These are the few things that we tend to see. There's a lot of relapses during these few years. There are a lot of new cases. Like in fact, one of the complications, the long COVID syndrome, is due to the long COVID syndrome, the anxiety and depression. That's why we have a lot of clients after contracted COVID, right? And then they started to feel depressed, or they started to have an anxiety symptom as well. Okay. You see, I always say writing a prescription to treat the mental health disorder is easy, but we need to do it the most effective route, the safest for them. All right. If you think a patient has high risk of suicidal, refer for admission. If you think the patient cannot manage the medication, get help from the family members. All right, to supervise the medication. All right, all these, get involved with the family members. It will be helpful. It will be helpful in terms of your management. Okay. So psychotropic drugs, is very useful, very helpful in treating a lot of mental health disorder. But if inappropriate prescribing, then of course it will cause more harm, right, than doing good. Okay. So next, I think this is my last slide. All right, okay, like I said, okay, I'm not showing you a lot of slides. I'm doing more on the talking part. All right, so is there anything else that you all want to discuss?
Dr. Sid, maybe you can touch a bit on the emergency management of the psychotropic medication. Sometimes the patients turn into psychotic condition in the clinic setting. So how do you manage this kind of patient? Sometimes there is no availability of haloperidol in the clinic. Yeah. So usually, how can we manage?
Yeah, if patient become aggressive, all right, of course, by the history, we need to rule out what are the causes. If a patient is a known case, kalau patient sebelumnya pernah didiagnose ada schizophrenia, or patient ada substance, like any substance that can cause aggression, contoh macam ice, amphetamine, ganja, cannabis, right, or sometimes some stimulant pills as well, like pil kuda, right? All these can cause patient to be aggressive. But a lot of time, I do receive referral patient coming in, elderly, become aggressive as well, right? Then of course we have to rule out what we have to find out what's the possibility that causes the aggression. Of course, substance, yeah, it can be due to substance. All right, schizophrenia, it can be due to defaulted treatment. Elderly, it might be due to delirium as well. All right, that's why we need to do check the underlying causes. Not every setting we will have IM, intramuscular haloperidol. Yes, I agree. Some clinics don't even have haloperidol itself. All right. So if let's say this is a psychotic patient, you are confident that patient is having relapses. All right, you can give patient some other antipsychotic like fast action such as olanzapine. All right, I think in the market, I mean, they have something called Zydis, but not every clinic will have it. Zydis is the oral dispersible, meaning you just put inside the mouth, it can melt. We have generic medications such as other brands which have the similar effect as well. All right, but of course, kalau you ada ubat macam tu, then you can serve the patient, ask the patient swallow the tablet first. But of course, some patients, some clinic might not have olanzapine. Then the other medication that can calm patient down with fast effect will be benzodiazepine. All right, the fast action, all right, will be alprazolam or diazepam. All right, of course, medication like clonazepam is going to take time. All right, fast action, alprazolam, diazepam might help to settle down the patient fast. But of course, if that one have to depends on patient, whether patient willing to swallow your tablets or not. All right, but if let's say patient is not keen to swallow or patient refuse to swallow, then parenteral injection will be another option if you have that. If you have that in your setting. All right, I suppose KK, kalau klinik kesihatan ada kan? It should have. All right. I can't hear you, sorry.
Any other questions? Maybe you can share, other than questions, you can share your opinion, your experience, or any difficulties that you are facing while managing your patients in the primary care setting. Yeah.
All right, any of the patient who come to you, all right, if you are having doubt on the patient, for example, those benzodiazepine sick patients, all right, they always come and tell you cannot sleep, anxious, you know, then if you have doubt on that, usually what I do is either I get their family members in to co-manage, all right, to co-manage, or I will sometimes limit the prescription, meaning I do not give them like 1 month, 2 month prescription. No, I give them weekly prescription, make them come over. All right, so they do not have the chance to overdose or misuse of the medication. For example, you know, patient always come prematurely. You prescribe 1 month, patient come 2 weeks, all right? Then you make it like, you know, or I only prescribe weekly, you come every week. If you come before your appointment, then you will not get your prescription, things like that. That helps them to control the usage of their benzodiazepine.
Okay, in the issue of availability, you see sometimes in one clinic, they prescribe with medication type A, but then the patient faces a lot of hassle to go to that clinic, and the patient goes to another clinic, the clinic B, but this clinic doesn't have the same medication with clinic A. So how do you change the medications so that the patients will benefit and do not really have a lot of side effects?
I mean, you discuss with the patient, all right? If patient already stable with one medication, all right, of course, we will try not to change the medication, all right? But of course, if patient is not well with the medication, katakan clinic A, makan 2-3 months, still not good, symptoms still not well controlled, patients still have a lot of symptoms, right? Of course, we can always change the medication. But of course, the first thing I usually do is to discuss with the patient. You know, there's one term that we commonly use now is called SDM, meaning the shared decision making. Meaning whatever decision we discuss, agree by both parties, the treating doctor and the patient, then we make the changes. All right. So if patient agree that the previous medication is not helping, all right, and wanted to try something else, all right, we usually taper down the medication slowly. We do not off the medication immediately, because if patient already on the medication for some time, this is to minimize the chances of withdrawal. So we usually will taper down the medication, right, instead of just off the previous medication.
Okay. SDM is on the SDM is on the one end, yeah, but on the other end is the problem where the psychotic patient, especially the acute ones, they are in denial or they have poor insight. And how do you tackle this kind of patients? Sometimes you need to influence the caregiver to give them in secret, to give them medication secretly. So how do you tackle this problem?
It actually depends, all right. But of course, right, we have a lot of medication which it can be served, right. For example, we have drops, we have antipsychotic drop. Like I mentioned, we have the oral dispersible medication. Even antidepressant also we have oral dispersible, all right. Meaning oral dispersible, meaning it will melt in the water. All right. So yes, as long as you can establish the diagnosis, patient is having poor insight, patient is refusing medication, all right, family agree, you get a consensus from the family members, you will do whatever is possible for the patient to receive the medication. Yes, I mean, I will, of course, I will try not to serve all patients, without patient aware of they are taking medication. But sometimes, all right, you can, instead of telling them, okay, this is an antipsychotic because you are having psychosis, it's not easy for them to accept it. Definitely, they will tell you, doctor, I'm not psychotic, you are psychotic. Alright, dia kata, doktor saya tak gila, you gila. We always have this kind of situation, but sometimes, alright, it really depends on the medication and how urgent that we need the patient to take the medication. If we think there's no way you can serve the medication, some paranoid patient, they don't even eat or drink food or drinks that you prepared, the family prepared for them, then they are so violent, then no choice, we have to send them to the hospital for proper care of the patient. All right, but if sometimes we can tell them, okay, this medication is going to make you feel relaxed, okay, it's going to help you to elevate your symptoms, right? Yeah, it's the same explanation, but in a more acceptable way. Patient, a lot of time they're willing to take it. If some patients, they are very rigid with the term of depression, psychotic. You tell them you got depression, you take antidepressant, they will refuse sometimes. But you tell them, okay, yes, your mood is not good, right? You're having some anxiety, all right? You're having some memory issue, emotion issues, all right? You need medication to help you to feel better, right? They are actually willing to take it. But they are very stigmatized with this term, psychotic disorder, psychiatric disorder, depression disorder, anxiety disorder.
Yeah. And another issue is usually about compliance. At the acute setting, maybe it's okay, it's easier, rather than once the patient has reached the stabilized state, then they refuse to take the medications, and then they come again in the acute condition. So how to make sure the patients comply with the medications? Because of
You
the
see,
stigma, of course, yeah.
one of it definitely because stigma. Of course, the second one I think you mentioned earlier is because of the cost as well. All right, because of cost as well. So I mean, 70% of our psychotic patients, basically our schizophrenia patients, 70%, they are having poor insight. They will default their treatment. Like you said, all right, they are not well, we get them treated, they are well, and then they will say that, oh, I'm well, I don't need medication. And then they go into the vicious cycle again and again. All right, this kind of patients sometimes, all right, we will try to use what we call that the parenteral injection methods. All right, we have a lot of new medication, monthly injection. All right, last time we used to do a lot of monthly injection with typical antipsychotic, but it comes along with a lot of side effects. For example, stiffness, hypersalivation, headache. That's why patients don't like it. But the latest development, we have a lot of new atypical antipsychotic injection. Right, even the latest technology, patient can inject every 3 months, meaning only 4 injections per month. All right, it's very convenient to the patient, but of course, cost is one of the issue. All right, they need to be able to sustain the cost. But this is one of the way to help with the compliance. You see, even in depressive patient, we have patients get well after 2-3 months, and then they default the medication, then they got relapse, they come back again. All right, that's why I always say it's not only the medication, but the family support, the psychoeducation, the psychotherapy really does a lot of help in terms of make sure the compliance of the medication, because we need them to understand. All right, we need them to understand the needs to continue the medication. All right, so that's why in psychiatry setting, we can't just touch and go, see patient fast in 5 minutes and then send them away. But we need to, after settle all the acute symptoms, all right, after explaining all the medication, the next way is to psychoeducation, not only to the patient, but also to the family members, to make them understand the cost of the treatment, the progress of the treatment, and to make them to be compliant to the medication. All right.
All right. Thank you very much, Dr. Sid. We have learned a lot from you, especially in the practical aspects, because all these are really being experienced in the primary care. Since we do not have any other questions, I would like to thank again Dr. Sid and all of you for your participations in this CME. And I hope you gain a lot of benefits from this CME, and you can use all the information as a help, as a tool in managing your patients in the primary care setting. For that, I would like to end this session. And thank you again from me, Dr. Faiza, and goodbye. Thank you.
Thank you.
Thank you so much.